go. There we go. Good evening. I'm John Miko. I'm the Executive Director of the Union League Legacy Foundation, and it's my pleasure to welcome you to the second in our series of programs on the COVID crisis and its impact on Philadelphia and on the Philadelphia region. The Union League Legacy Foundation is a nonprofit charity of the Union League of Philadelphia, guided by the United States Constitution and the histories, the values, the spirit of the Union League. We endeavor to inspire and educate citizen leaders, members, the public, and scholars alike. We do this through programs on the Constitution, on civics education for high school students, through programs like our scholarship program, and through programs like tonight's public affairs program. Recently, we've taken on the additional responsibility of raising funds and administering the Union League Employees Emergency Fund. And my thanks to the many members who have given so generously to this fund. Please know that your generosity is impacting dozens of families and Union League employees as we speak, and they are very grateful for your support. I'd also like to thank our generous benefactors who support the work of the Legacy Foundation all throughout the year, our Founders Circle and Lincoln Circle leaders in particular. It's only through your generosity, through your voluntary support, that we can provide programs that reach over 100,000 people every year. So a few other items for tonight. We are going to have Q&A. And for those of you who are not used to Zoom, the Q&A is down on the bottom. There's a little button down there. And you can ask questions throughout the program. Our moderator will get to as many of them as he can throughout the program. You cannot, they cannot hear or see you. If you're new to Zoom, they can't see you. The only way to communicate is by asking a question. And if you're on YouTube, you can't do that, but know that our YouTube channel will be carrying this and all the programs that we're doing virtually of the Legacy Foundation on our YouTube channel. So with that, it is my pleasure to turn it over to the chair of the program committee of the Union League Legacy Foundation, Mr. Steve Target. Steve.
Great, thanks, John. And just to take a moment here to make sure we thank you and your colleagues in the Legacy Foundation. You all have done a tremendous amount of hard work on our behalf, and all the Union League membership is very appreciative of the hard work you've been doing and putting together these sort of events. I did have the opportunity this afternoon to also speak to President Charlie Davidson, and he had a couple updates he'd like me to share with you all. Firstly, as I think we know, the Union League Golf Club at Torresdale and National both opened up last weekend, which was tremendous. All the tee times were taken up. There was a great deal of takeout, not only at Torresdale and National and Union League House. So things seem to be moving along a little slower than we would all like, but it was great to get everybody out in the course and together with each other. President Davidson would also like to note that he's appointed a new ad hoc committee to work closely with the staff to start developing our plan to reopen the Union League when we're able to. And the committee is chaired by Vice President Craig Mills and includes committee members such as Vice President Bob Cavalier, Dan Fitzpatrick, Harry Hill, and board member Peter Madden. Charlie does send his regards to our membership and well wishes for everybody, and looks forward to seeing you as soon as we're able to see each other. And from the Union League membership, Charlie, and to your team, we'd like to thank you as well. Your leadership has been strong, and we appreciate everything you've done on our behalf. Now it's my pleasure to introduce, and an honor as well, to introduce my good friend, Ed Trzanski. Any of you who know Ed know that his resume is long and deep. Ed is a tremendous citizen and patriot. He asked me to make sure I didn't go on and on about his background, so I'd like to make sure that I highlight a couple things here. But Ed's been a great service, not only to our community, but our country. And currently, Ed is a life member of the Union League. He's a past vice president of the Union League. He held a variety of positions, leading from leadership positions from membership to library and foundations and everything in between. As we know, Ed's very busy. He's very engaged. He's a highly sought after speaker on many topics related to the government, politics, and worldly affairs. And if you haven't, look out for him. He's on TV and radio quite often. So it's my pleasure to now pass the microphone, so to speak, over to Mr. Trzanski, who also, as appropriate for this evening's talk, is the chairman of the board of Jefferson Health in the Northeast Division. Ed, take it away.
Steve, thanks very much. And thank you to John and Kira, the whole team at the Union League, Charlie Davidson, and to everyone listening in tonight. A number of years ago, when Steve Klasko, the visionary who built Jefferson Health into this 14 hospital, 26,000 employee, $5.3 billion a year operation, which has the largest number of covered lives in our region. When he confronted the need to bring in a top operations person, we had a nationwide search and we struck gold in Dallas, Texas. And that's where we found Dr. Bruce Meyer. Bruce Meyer is a good friend, a colleague, and a loyal Union League member, I'm proud to say. And he comes from a family that is steeped in tradition of service to the country. His grandfather taught at the Naval Academy, taught mathematics for 40 years. In fact, Granddad is buried in the cemetery at the Academy. His father was in the Navy Medical Corps for 20 years. And these two gentlemen instilled in their offspring the kind of service that led him into into the medical profession in a way that, well, quite frankly, I'm going to have to read it. Bruce, in addition to his medical degree, he has an MBA, but his medical specialty was high order multiple gestations. Let me translate. He is the #1 doctor to have delivered triplets in recorded history in this country. I believe I have that right. And Bruce, tell us a little bit more about your experience in high order multiple gestations.
So back in the day, this is not that long ago, where our colleagues in reproductive endocrinology didn't really understand how to limit the number of babies that they were putting into the womb. We had a lot of people got pregnant with a lot of babies. So by hook or crook and happenstance, I turned out to be somebody who took care of a lot of those patients. And I've delivered 1 set of octuplets, 2 sets of septuplets, 4 sets of sextuplets. At the last time, I'm a little over 200 sets of triplets. And I have the largest series of triplet outcomes in the medical literature currently existing. I also have some other odd claims to fame. I originally started out as a whole animal sheep physiologist studying diabetes and pregnancy. And so I'm probably the only obstetrician with a publication in the Australia-New Zealand Journal of Veterinary Medicine, because I did ultrasound to determine the normal growth curves of the fetal sheep.
Well, so Bruce has delivered more than 10,000 babies. They're very lucky to have had him as their doctor. We're lucky to have him today. And by the way, he's a man who loves a challenge. He and his wife, Christy Little, Dr. Christy Little, are the parents of 7 children, 2 of whom were adopted from desperate situations. So Bruce is a man who's used to a challenge, and it's a good thing, because Bruce, right now, what we are going through is unprecedented in the life of anyone drawing breath on the planet, quite frankly. Certainly in this country, we've not seen anything like this in more than a century. And the public can be excused if it's a bit confused. So very smart people in high places like Dr. Anthony Fauci early on said, this is like the regular flu, don't worry about it, it's going to be fine. Then he had a much more dire take on the matter. We were told it could be 1 million to 2 million people losing their lives. That was brought down to between 60 and 100,000. We're well beyond 60,000. We were told not to wear masks. You would do more harm than good. You would wind up collecting bacteria on the outside of the mask, and you would infect yourself taking it off. And now we're being told we're not allowed out of our houses without a mask. So Bruce, let's try to put this in a meaningful context so that people understand where we started, where we are, where we're going to be. And I think the best way is for me to ask you to comment on something you said at a meeting this morning, which I attended by Zoom. You said that COVID is, and I quote, a safety crisis. What did you mean by that?
Yeah, so this is a novel virus. And by that, I mean, no one has immunity. No one has been ever exposed to it before. And so that means that everyone is vulnerable to the virus. And when that happens, it means that safety becomes the priority for us. Safety for patients who are sick, safety for our staff in healthcare who are taking care of the sick, but it's also safety for our entire community. Because our entire community is vulnerable, and because we know that people who have other comorbidities in terms of their health are extraordinarily vulnerable, figuring out ways to keep people safe becomes the number one priority. And so you're right, there've been a lot of confusing messages and a lot of different models. This is the trouble with every predictive model, is they are all always wrong. There are some that are very informative, but they're always going to be wrong. And because we had no knowledge of this disease at all, those kind of predictive models used incomplete information. And so you have wide variation in what the predictions were. I think at this point, we're really trying to focus on the safety approach. And that's in multiple dimensions. From a healthcare standpoint, that's things like creating new protocols of how we see people, enhanced cleaning protocols, screening exams and questions for everybody who's entering our hospital to make sure that we're not spreading the disease. It's improving and increasing our testing. I mean, remember that testing for COVID-19 did not exist until January of this year, literally anywhere in the world. So not surprisingly, the number of tests and how frequently we ought to test people, who ought to get tested, et cetera, is a still evolving decision across the country and here in Philadelphia. I mean, for Jefferson, a lot of that has been a heavy focus on personal protective equipment. We're trying to protect our staff because remember that most of what we did originally was to try to create containment of the disease. If we could keep it contained to a very small number of people, like SARS or MERS was, then we can kind of stamp it out and keep it very confined. Unfortunately, we were not able to do that worldwide. Some of that is because this is a disease where you have asymptomatic carriers for a number of days before they become symptomatic. In fact, some people are asymptomatic carriers and never actually get any symptoms while they recover from their infection. And so that makes it difficult to know who and what circumstances and how to contain the disease. So we relatively rapidly moved to this mitigation strategy. Once you move to a mitigation strategy, it is about what is your true goal. And the goal is to reduce the number of deaths, but more importantly, our real goal in this country has been to not overwhelm the health system to a point where we have unnecessary deaths. And you've heard lots of reports out of New York where people died at home, where people were dying in emergency rooms because they didn't have ventilators, where healthcare professionals were getting infected because they didn't have appropriate personal protective equipment, those kinds of things. We're working to ensure that that doesn't happen in Philadelphia and doesn't happen across the rest of the country, and that we're helping our colleagues in New York tamp that down. We're in full mitigation strategy right now. This virus has escaped containment in this country and across the world. So that means that safety is the way we have to do it, and the way we can prevent as many deaths as possible is to ensure that we've got the maximum workforce in the healthcare side of the world. So we've got to protect our staff and try to ensure that none of our staff get infected with the disease because they were taking care of patients.
So Bruce, speak about the impact of COVID, and very specifically in terms of what protocols were imposed upon hospitals and how that has affected the capacity of hospitals to meet the challenges that you speak of.
Sure. So first I would say, in order to ensure that we had the maximum amount of personal protective equipment and the maximum capacity in our hospitals, because we really had no idea in January and February, and even into March, what kind of volumes we would be facing for this disease. Most hospitals in the Philadelphia region, even before the governor's order, ceased doing what were called elective cases. Now, as a physician, I would argue if we decide to do surgery, there's nothing elective about that unless we're talking pure cosmetics. But there are a lot of surgeries where we could say, you know, whether we do this today or we do this a month from now, probably not going to affect your outcome. And we made the decision to postpone things that could be postponed for 30 or 45 days in order to preserve that capacity in the hospital. Now we're far past that 30 to 45 day time frame now, and we are very concerned about a second wave of poor healthcare outcomes because of those postponed cases. But what affected the hospitals profoundly, and Jefferson is no different than any of our colleagues across the region, is that the things that bring in the most money, candidly, are procedures and surgeries. The things that bring in the least money are medical admissions. COVID is an entirely medical admission. The vast majority of COVID patients have pneumonia, and they come in for that medical care that we give for pneumonia. We don't operate on them. And because by happenstance in the 1960s, when the payment systems were derived at the federal level, most of the people sitting around the table were surgeons and proceduralists. We get paid way better for surgery and doing something to people than we get paid for evaluating and managing them. What that's meant for hospitals across the country, and Philadelphia is no different, Jefferson is no different, is that about a third of our top line revenue has disappeared. At the same time, our expenses have actually gone up because the care of a COVID patient is much more complex, much more resource intensive, and much longer than that of the average pneumonia patient. For ease of math, your average pneumonia patient who comes to the hospital stays for 4 days and doesn't go to the ICU. Your average COVID patient stays for 10 days. And if you go to the ICU, and right now that's about a third of the COVID patients, your average length of stay is 16 days, 6 of those being in the ICU. And beyond that, the vast majority of patients who go to the ICU with COVID, about 80% of them wind up on a ventilator. That ventilator requires intense resource management. When we're talking about a vulnerable workforce, we have to do that personal protective equipment piece for them. And that personal protective equipment means that we have to change it out appropriately over time. We have to ensure that other people are not exposed when that nurse or that aide leaves the room. And we've had to staff more heavily because ventilator patients require heavier staffing than non-ventilator patients.
Bruce, a question just came up from someone who said that they cannot wait any longer for the procedure they need. What is your advice to a person who needs what's called elective and you've explained as non-elective surgery? What's your advice to them?
I would urge them to contact their provider, tomorrow. Here's why. We now have a fairly decent handle on the volumes of what's going on with COVID. We're kind of in a plateau phase in terms of the volumes here in Philadelphia. And pretty much every hospital has capacity to be able to manage those essential kinds of care. I will say as an example, at Jefferson, we have 60% of our patients that we're taking care of right now are not COVID patients. And we have not had a single case where we have had transmission of COVID from a COVID positive patient to a COVID negative patient in our hospital. And I think truthfully, that's the experience of our peers here in the region. So we know now how to keep those patients cohorted and segregated and to protect the non-COVID patient from the COVID patient. So I would say it's safe to come back to your provider and to your hospital and to your clinic and to your ambulatory surgery center. And we are starting to reopen those places. We were never truly closed. Our ambulatory surgery centers were closed down, but we were never closed for care. What we're trying to do is encourage people to come back, contact their provider, and arrange for that appropriate procedure so that we can relieve pain and suffering, so that we can prevent long-term ill effects on your health.
Now, the only thing that is more sought after than a roll of toilet paper is one of these. It's an N95 mask. Talk about the needs for PPE. Tell us what PPE is, what we used to pay, what we're currently paying, and what the challenges are in providing care when you need PPE.
So personal protective equipment are the barriers to the virus to getting to people's respiratory tract or other mucosal surfaces. So personal protective equipment involves masks, it involves face shields, and it involves gowns and gloves and booties. So that we can collect, in essence, any virus that people are exposed to collects on that equipment, and we can take that equipment off safely, and then we can put it in the trash and sterilize it in an appropriate way so that nobody else gets infected, so that you don't spread from person to person. Those personal protective equipment things have become in incredible short supply. And like any law of economics, supply and demand has meant that prices have changed. So that mask that you just showed, in January, that mask cost us about 55 cents per mask. Today, you cannot buy one of those masks for less than $8. In addition, not surprisingly, there are knockoff masks. So there are unfortunately, we're seeing most of them from China, where they are producing masks that do not filter the 95% of particulate matter and viral matter out of the air as you breathe in. They filter less than half of it, sometimes even less than 10% of it, but it looks like something that looks like the same mask. There's an actual functionality to those masks in the same way that there's a functionality to the gowns. So the gowns have to have a barrier effect that prevents viral particles from getting through the gown. Today, gowns are in very short supply, and the burn rate, meaning how many gowns do we use a day, is very, very high. So a single-use disposable gown that we used to purchase for 22 cents in January now costs between $11 and $12, and you can purchase them as high as 17 if you would like. It's tremendous inflation, really startling. And we are seeing the Chinese government actually interfere with shipments from China. So I don't want to get too deep into politics, but we created a supply chain, candidly, where these materials came mostly from China, and China has decided that they need to use it for their own population. And so their government has prevented manufacturers who have sold that material to folks in America or Italy or Spain even from getting shipped over. That has certainly occurred for Jefferson. I know it's occurred for colleagues at Penn because I've talked to them. It is a struggle right now. If you think of the burn rate in the sense of how many gowns do we use a day, right now our average at Jefferson alone is 14,000 gowns per day. If you consider the cost ratio of I used to purchase that for less than 20 cents, now I'm purchasing that for greater than $10, and I'm using 14,000 of them a day every single day. You can see that the cost adds up relatively quickly.
Bruce, and again, this is an N95. Don't buy a KN95.
A KN95 is a knockoff that doesn't filter in the same way that an N95 filters. That's correct.
So Bruce, I pulled some statistics, and these are from yesterday. So as of yesterday, Pennsylvania was 6th in total cases we were 11th in cases per 100,000, and we were 8th in deaths per 100,000. So in Philadelphia, any idea how many people have acquired COVID and died of it? And the same question someone asked about not just Philadelphia, but Jefferson.
I'll give you the Jefferson data first and then the larger data next. At Jefferson, we have performed about 40,000 COVID tests, just over 40,000. Of those, about 8,500 of them have been positive. So we are following 8,500 COVID patients who are recovering or have recovered. Of those 8,500, about 2,700 of them have been hospitalized, so about a third. And we have lost 386 souls at Jefferson. If we look at the greater Philadelphia region, Jefferson is about 40% of the total volume. We're actually the largest number of COVID patients across the region. So the region has had, give or take, 20,000 COVID positive tests. The region has had, give or take, about 6,000, about 5,500 of those people hospitalized at one point. And the region has lost a little over 1,100 souls to COVID. Across Pennsylvania, that number is about double. No question, southeastern Pennsylvania and the greater Philadelphia region is by far the hardest hit with COVID of any part of Pennsylvania. A little different in New Jersey. Southern New Jersey, while we've had a lot of cases, northern New Jersey, without question, has been hit much, much harder than southern New Jersey.
Bruce, you and I often trade, and this is late at night, we trade articles from scholarly and news sources about COVID, its spread. There's something interesting that we picked up on. New York City has about a third of all the COVID cases and fatalities in the United States. California, which is 40 million people and more proximate to China, much higher movement between itself and China, it's fourth. So how is it that New York City and Detroit are so far ahead of California? I know there's some speculation here, but a lot of this is speculative based on data that we're acquiring to try to understand what's happening.
Sure. So first I would say it's, interestingly, if you look at the genome of the genetics of the COVID virus, the majority of COVID cases in the United States are actually related to the European strain that came out of Italy, Spain, and Great Britain. And the majority of that travel actually tends to come to East Coast rather than West Coast. So that's a piece of it. We didn't ban travel from Europe for a long time into this pandemic. And credit President Trump, he banned travel from China very early in the pandemic. At the time, we weren't even calling it a pandemic, it was an epidemic. So that's one piece. The second piece is that if you look at East Coast, and I would add Chicago and Detroit to this, major metropolitan areas, there is a much, much more advanced public transportation system in which large numbers of people use that public transportation system to get to and from work and to and from daily activities. On the West Coast, in the Midwest, in the South, we really have very, very underdeveloped public transportation systems. In the West Coast and Texas, where I came from before coming to Philadelphia, it's everybody in their own car driving to work every single day. Nobody is riding a train where there's 50 of my closest friends in this car and another 50 of them in the car in front and another 50 in the car in back. Or riding a bus where it's 45 of my closest friends and we're all sitting very close together. You don't have that in Los Angeles in any large degree. You don't have it in Dallas. You don't have it in Houston. You don't have it in St. Louis. And so when the virus came over from Europe, it spread much more rapidly because of the public transportation. It's what we call super spreader events, which is that one person on that train spreads it to the other 40, 50 people in the train car. those people then spread it to the people they work with and the people they're at home with. You just don't have that same kind of super spreader phenomena where everybody is in their own car coming to and from work.
Bruce, and principally, the way to get this is someone has it, you're spending time with them, and it's their breath carrying moisture that you wind up inhaling. Is that correct?
Correct. So it's respiratory micro droplets. You can't see them. Every time we speak, every time we breathe, there are wet micro droplets that come out of our mouth and our nose. And COVID travels on those micro droplets. And when those micro droplets land on somebody's hand or face or clothing, and then you touch a mucous membrane, whether it's your mouth or your nose or your eyes, typically, COVID binds tightly and is very, very invasive to those mucous membranes. And in particular, it is very, very invasive and damaging to the membrane that is in the lung. In the alveolar sac, the tiny micro sacs that help you exchange oxygen and carbon dioxide, there's a material called surfactant, and surfactant decreases surface pressure. I apologize, I'm getting into physics now. What surfactant does is it allows your lung to stay open when you breathe out, because normally if you didn't have decreased surface pressure, the lung would just collapse. Surfactant helps keep it open. The virus binds to the cells that make surfactant, and it makes the lung it makes the lung much more stiff, less malleable. And so lung tends to collapse. That collapsing of the lung means you can't exchange oxygen and carbon dioxide properly, means your oxygen level in your blood goes down, and you get into respiratory distress. And that's the bulk of serious disease in COVID. But COVID is very, very effective at spreading on mucous membranes, throughout the body, and that simple, spraying of micro droplets that then gets on your face or gets on your hands or gets on your clothes. You then touch yourself, and then we rub our nose like this, like we all normally do, or we scratch our eye or that kind of thing, and boom, you're infected. And it is in contrast, as an example, to the common flu that we see every year, the flu is a much less effective invasive virus than coronavirus is. So coronavirus is about 2.5 times as infectious as the average flu is that we see. And so what that means is that when you're in small spaces where people are breathing on each other, in essence, you're a lot more likely to be exposed to the virus, and then that virus is a lot more likely to cause infection in you as a person.
Bruce, there's a question about comorbidities and nursing homes. So talk about nursing homes and the vulnerability in nursing homes and the kind of comorbidities that we see in terms of the demographics of the patients who are succumbing to the disease.
Sure. So there are kind of two different things going on there in our nursing home and assisted living population. One is, as we all get older, the amount of surfactant we produce is less. So our lungs are stiffer. If you then get an organism like COVID that attaches and makes your lung even worse, then you if you only started at sort of 70 or 50% of normal capacity, and we degrade that by 30%, now you're in a place where you can get very desperately ill and need an intensive care unit. If you're a 25-year-old, that 20% decrease, I mean, you feel bad, but you're not in a place where you can't exchange enough oxygen in order to stay alive. So that's one factor. So older people, much more vulnerable just because of the effects of age on their lung. The second piece is that it is clear that particularly in folks that have other kinds of lung diseases for same kinds of reason as aging, so COPD or asthma or that kind of thing, degrades your lungs' capacity to withstand the disease. And then other things like obesity, diabetes, and poorly controlled hypertension in particular mean that there's a particular receptor in the vascular tree. And now I'm getting way deep in the weeds, so I'll try to do it in as easy a fashion as I can. That receptor is made much more vulnerable to the virus when you have obesity or diabetes or poorly controlled hypertension. So you are much more vulnerable to a high viral load that then causes damage to the tissue inside your vascular tree, your heart, your blood vessels, and inside your lung.
Three names very prominent in the news: hydroxychloroquine, remdesivir, Z-Pak. What are your views, and what's Jefferson doing, and what's being done nationally, to the extent you can talk about those three, and the quest for antivirals, and what role can antivirals play moving forward?
Sure. So hydroxychloroquine is an anti-malarial drug that has been used for probably 4 decades in patients with malaria. It is something that that, at least in theory, in the laboratory, interferes with the virus's ability to bind to that receptor that I talked about. And so in theory, hydroxychloroquine should be a drug that should help prevent the virus from damaging cells. In actual clinical trials, unfortunately, hydroxychloroquine has not been shown to actually improve either how long it takes you to get well, or whether you get hospitalized or not, or whether in fact you die from COVID. We have no data right now that says it in fact improves outcomes for patients. That's unfortunate. Erythromycin derivative, when combined with hydroxychloroquine in malaria, has an enhancing effect in preventing the malarium from infecting blood cells. And so we thought that maybe if you added that to hydroxychloroquine, that would have an effect on coronavirus. Again, unfortunately, turns out not to be the case. We have not got any evidence right now that, and there are multiple clinical trials that have gone on, that it in fact improves outcomes in any way. And there are side effects, particularly for those two drugs in combination. They cause heart rhythm problems that can be very detrimental and can in fact sometimes be fatal. So right now, that's actually not part of our treatment algorithm. Remdesivir, which is an antiviral drug that was developed for Ebola and SARS, which didn't actually work very well in Ebola and SARS, does have more promise. So the NIH has what's called a randomized double-blinded trial going on, which means neither the patient nor the doctor knows what drug you're getting or whether you're getting the placebo. They released some of their preliminary data, and this is in patients, all of whom were in an intensive care unit already. And remdesivir did seem to decrease significantly their stay in the hospital by 4 to 5 days. It did not have a statistically significant effect on mortality, but it was only in 423 patients. So we think there's a lot of promise there. We need more data. That trial is ongoing. We're in fact part of the trial. Our colleagues at Einstein are part of the trial. We again don't know which drug the patient is getting, but on the basis of those preliminary results, the Food and Drug Administration approved remdesivir for emergency use. And then the CDC now is in control of all of the doses of remdesivir that are not on clinical trial. And they are then allocating them out to hospitals in hotspot regions based on numbers of cases that are currently in that region. And for what is really experimental compassionate use for patients in intensive care units who are in extremis. So you're going to have to apply on a case-by-case basis to the CDC right now, because it is the production of it is relatively small still compared to the number of cases across the country.
How about plasma treatment?
Yeah, so I think the thing that at Jefferson in particular we are really excited about is what's called convalescent plasma. So remember I talked about the sort of 8,000 patients we've diagnosed, so right now about 6,000 of those people are home, recovered, no longer COVID positive by culture, by PCR test. And we are contacting those folks, and they have been very generous to come in and donate plasma. Plasma, which has the antibodies that your body has developed to kill the coronavirus, can then be transfused into people who are still infected. And so we are using that clinically right now, and have seen, and again, these are anecdotal results because we've done it in about 36 patients right now, but we've seen really remarkable improvements, and to date have no mortality in any of the patients who have received convalescent plasma. The limitation of convalescent plasma is you have to find somebody who's already had coronavirus, is now no longer infectious, has made antibody, and is willing to come in and donate that serum to have somebody else. And then the trouble is that a single dose of serum is not sufficient. You need probably in the neighborhood of 6 to 10 doses, which means you need 6 to 10 people to treat to give plasma to treat one person. So right now we need a lot more people to recover from coronavirus. So, and then to be generous enough to donate plasma to be able to try to save more people using convalescent plasma. But we are absolutely using that treatment. Penn and Jefferson are the only folks that have a blood bank that's capable of doing that right now. I know we're both actively engaged in trying to help patients in our hospitals with that treatment.
Bruce, a question about being tested. How do you determine whether you should be tested? How do you go about being tested? And initially, it was very unpleasant. Has the 5-minute test yet gotten to us?
The answer to that is no, but soon. The current standard to test for COVID is what's called a nasopharyngeal swab. That involves taking an 8-inch long swab that it's not a Q-tip, but it looks like a Q-tip. It has to have very special material on the end of it. And you have to put that through someone's nose all the way to the back of their throat. It is an intensely uncomfortable experience. It also means that as we do that, we expose whoever's doing the test to that aerosolized droplet of the COVID. So it's a dangerous test for people to be doing. Many of you may have seen our folks who've nicknamed themselves the swab squad out. Because that requires personal protective equipment, it is not available everywhere in any place. So lots of organizations, Jefferson included, we have set up in parking lots, on sidewalks, in various places to be able to have drive-by testing. You don't get out of your car. We do it through the window of your car kind of thing. That's the gold standard. There is a test that involves the same, that test takes 4 to 6 hours in a laboratory to get back. The problem is there is a limitation in the amount of reagent, and the reagents are controlled by the government and by the companies that manufacture them. So every organization gets an allotment based on what they've managed to negotiate with those folks. So as an example, Jefferson can do in-house with the reagent they give us about 1,400 tests a day. That's it. We're currently doing about 3,000 of those tests. The other 1,600 get sent out to commercial laboratories like LabCorp and Quest and take right now 2 to 3 days to get back. So that's problematic for us. There is a quick test, a 15-minute test that you can do. The problem is it has a very high false negative rate. So about 15% of the time when you have COVID and you use that quick test, it says that you're negative, but you're actually positive. That's problematic in terms of treating patients. So we're not using that very much, except in our emergency rooms for patients who come in for other kinds of complaints. So we're doing a 15-minute test in somebody who comes in with a car wreck because we want to know whether you're COVID positive or not, because we need to know what to do with our staff. The hope on the horizon are twofold. One would be what's called an oral swab, where you basically just stick it between your cheek and gum for 10 seconds, and that's enough. We're testing that. That's very simple. And again, we could provide people with test kits, but it means that you have to have a swab with the special material that's manufactured, and we are struggling around having enough swabs. The real goal, magic bullet would be a saliva test, where I hand you a tube and I say, spit into the tube and fill it to the dark line on the tube, and then give me the tube back. Those could be done at home. Those could be done in business offices. Those could be done in clinics. And you would simply need to then sterilely wipe the tube and get it picked up by a laboratory that can then run the test. We are currently doing tests on that at Jefferson. I know our colleagues at Penn are doing the same test. We expect to validate that within the next 2 to 3 weeks. And we're hoping that by June, we will be able to say to patients, don't drive up. You no longer need to drive up. You can go to your provider's office. In fact, we would be able to provide those kinds of tubes to businesses across the greater Philadelphia region. And we just have to figure out a mechanism to be able to have those samples picked up and then run. And we're working very heavily with national companies to gain testing capacity in that way. For Jefferson, as an example, we've secured up to 20,000 tests for that once we validated it on a daily basis. That's a game changer for us in terms of testing, folks. Because today, what we would say is, if you are symptomatic, you should talk to your provider, but as long as your provider recommends it, you should come to one of our drive-by or walk-by spots. If you're not symptomatic, we don't have enough tests to test you. If you have been exposed, but you are not symptomatic, we don't have enough tests to test you right now. If the saliva test proves out, then we could say, great, go get a tube from your doctor's office or from your business or from one of our sidewalk places, spit in the tube, give us the tube to run, make sure we have your contact information, et cetera. And then we can really ramp that up and provide some lessening of the anxiety that exists all across our society right now about this disease.
Bruce, two related questions, and they are more hopes than anything. Herd immunity and the hyper race for the vaccine. What do you think, a time frame, what's happening in both those cases?
So herd immunity is the place at which enough people in the community are immune to the disease that the disease has a hard time spreading. Typically, that means that about 80% of the people in a community are immune to the disease. The truth right now is that we have no idea how many people in our community are immune to this disease, because we've only been able to test symptomatic folks. We don't know how many people were asymptomatic and got over the disease, or had minimal symptoms and got over the disease. If you look at the tests that have been done in confined populations, so as an example, the cruise ship, where they had 1,500 people and they tested all 1,500 for COVID. What they found was that 700 of those people had been exposed to COVID, but only about 150 of them had symptoms. If that's really true, that half of the population results in that level of symptomatology being, that half of that population exposed and having the disease results in that level of symptomatology, it might be that we are approaching herd immunity in the Philadelphia region even now. But we have no way of knowing until we can test up. So that's herd immunity issue. The vaccine quest, there are over 90 different vaccine development trials ongoing in the world right now. One of them is at Jefferson, one of them is at Penn. And I have tremendous respect for Dr. Fauci, and and he went public saying he believes we will have a vaccine by December. Personally, and our team at Jefferson thinks that's a little optimistic. The reason for that is, first you have to test and see if the vaccine is dangerous to people. Then you have to test and see if what dose of vaccine actually provides antibodies that create immunity. Then you have to see if you can produce that vaccine in a large enough group to be able to vaccinate a population. And those are challenging things that take some time. So we think that we will have a vaccine in this country by this time next year with probably 80 to 90% certainty. I think December's a little optimistic, but we would all love it if that comes true. We would have to get lucky for December to come true. And by lucky, I mean that one of these early trial vaccines would have to be shown to be very effective with the very first dose that we try. Because typically with vaccines, we try a dose, it doesn't give enough immunity. We bump up the dose that doesn't give enough immunity. We bump up the dose that doesn't give enough immunity. Then we find the right dose. Because if we give too much, we make people sick and we have side effects of the vaccine. So we have to get lucky a little bit for that to occur. But I do really actually believe that given the volume of vaccine trials going on, one of them will hit. And then the issue is, can we mass produce it? Some of these vaccines are based on current vaccine methodology. So as an example, at Jefferson, our vaccine trial is based on a methodology used for rabies vaccine, for which literally tens of millions of people have been tested, and it's shown to be safe. And it is very, very easy to mass produce, and you could convert current flu vaccination things, as an example, into this vaccine very, very quickly. The question is, can we get the dose right, and can we produce immunity with that dose early? That's one example. Everybody's vaccine has kind of the same kind of situation. Some of them don't have a mass production that's easy to do. Some of them have not got the same kind of vector tested in millions of people, and so you're going to have to test more people to make sure it's safe. So lots of sort of complex permutations of this, but I really do believe, and our experts in our vaccine center under Matthias Schnell really believe that by this time next year, we will have an effective vaccine. The question is, what's going to happen between now and this time next year? I mean, as we were talking earlier today, as a business person, right? Leave aside the healthcare thing. Our economy has been shattered by this disease and by the efforts that we have made in order to contain the disease. The idea that we would allow our economy to continue in this shattered way through December or January of next year simply means that we will have abject poverty, craziness in our streets. People won't be able to pay for food. We can't afford that as a society. So we're going to have to balance, and this is what you're seeing with the governors trying to make decisions of, we need to open up our economies so that the enormous number of people who are unemployed can try to get back employed, so that poverty doesn't become a huge after effect of COVID, as an example.
So Bruce, you've spoken very eloquently about this, and you're president of Jefferson Health, you're executive vice president of the university. It's bringing the clinical together with the practical. Let's open the aperture of the lens, look more broadly at this issue. How do we move forward to get to the point where we don't have to go through what we've just been going through and endangering our economy, the livelihoods of tens of millions, and then setting off a cascade of public health crises of people who have food insecurity, health insecurity, housing insecurity, every imaginable plague that came out of the Great Depression and the Spanish flu put together. How do we go forward?
Well, obviously, once we have a vaccine and we can get herd immunity from the vaccine, that allows us to kind of go back to the kind of life that we had before. You won't have to wear masks. You won't have to socially distance. If we can get a treatment, if remdesivir proves out, as an example, that's more effective, where we can prevent the kind of morbidity and mortality to people that we're seeing right now, that would allow us to say to people, you can move away from those kinds of socially distancing and mask wearing kinds of behaviors. Failing that, or I would say really in the interim, until one of those things proves out, we're going to need to continue to wear masks. And the reason to wear masks is for twofold. One is, well, it's really threefold. One is if somebody's breathing on you, that mask will capture those micro droplets and they will not contact your mucous membranes. The second is the mask kind of reminds us to stop touching our faces all the time, which is just natural human behavior. And then the third thing is if you are somebody who is asymptomatic and doesn't know it and is shedding virus, the mask catches the virus that you breathe out and you're not exposing other people. So that masking behavior probably needs to continue until we have effective treatments and or herd immunity from vaccine, or we can prove that there's in fact herd immunity because we just didn't know how many people had gotten infected because it was relatively mild or asymptomatic in them. The social distancing issue is because even with a mask on, some of those micro droplets escape around the mask and get onto surfaces and things like that. If we stay far enough apart from each other, the virus drops to the ground and we generally don't rub our hands on the ground and then touch ourselves, right? And that is why, in fact, being outside has some value because wind tends to make the viral droplets drop to the ground much more quickly. So social distancing and mask wearing is probably going to become something that we need to do, like I say, until we get to those endpoints. Meanwhile, the truth is, I would say, we need to open up the rest of our world. Now, that is complex in the sense of social distancing for the hospitality industry and the dining industry is complicated. And do we have a business model that allows those things to continue? That's challenging. But other businesses need to get on with business. I think, and people ask me all the time about sporting events. What I worry about in sporting events, if we all go to the Eagles game and 80,000 of us gather together and we're all packed in there, walking on causeways, sitting next to each other, going to the bathroom, et cetera, the chance of spread is very, very high. So if this fall we don't have a way to contain the disease more effectively, we probably need to think about how many people can attend a game. The idea, though, is if we socially distance and we mask, we will be able to get away from the mitigation strategy that we are in right now. Case volume will go down, and we can move to a containment strategy with testing, where we're doing enough testing to identify people who are ill or who are shedding virus, and we quarantine them, and therefore they're not spreading it across the rest of society. So that's really, to me, it is let's get past this wave, let's socially distance and wear masks, and let's move to containment strategy so that people can get on with their lives and businesses can get on with their business. And we're going to have to deal with the complexity of the hospitality and dining industry. That's just complex, and we're going to have to work that through over time.
Bruce, you and I have the privilege of spending time with some of the most dedicated, wonderful, courageous people ever. How is the workforce holding up?
It's hard. I'll just speak for Jefferson, although I think candidly my colleagues at other healthcare systems around would say the same things. Our nursing staff, our supply chain team, the people who work in the hospital every day and clean the rooms, the people who bring food into patients' rooms, the staff at the front desk, et cetera, are unbelievably courageous every day, showing up. They are resilient. They are determined to save as many lives as they possibly can. And they are making great sacrifices with their families and themselves in an effort to do that. My admiration for their compassion, for their courage, for their integrity is immeasurable. But it is deeply stressful. For context, in an average 8-week period pre-COVID at Jefferson, and we're a quaternary care, highly complex organization taking care of the sickest of the sick. In our intensive care units, in 8 weeks, we would have seen an average of about 22 people die. In this past 8 weeks, we have seen 386 people die. That's hard. That's emotionally hard on people. And we are doing everything we can to support them from a mental health standpoint, from a support group standpoint, to support their families, et cetera. but it's hard. It is deeply stressful, and we are testing the resilience of our staff at every medical center across our region. And we're going to have to support them far beyond when this episode ends, because we're candidly worried about sort of a PTSD-like phenomena of folks who just can't face coming back to the ICU, or really the stress, because nobody's had time to process what they have experienced yet. And once they start to process that, we worry about what is the effect on their home life, what is the effect on their mental health, and those kinds of things. So we're going to need to support our healthcare heroes for months, perhaps years to come, with more behavioral health support and more community-based support. We got to rally around people, not just in this acute episode, but we got to stay rallied around our folk for many months to come.
Bruce, thank you very much. I'll just mention, for the benefit of everyone online, if you go to Jefferson's webpage, we have a COVID-19 section where we provide information that you can find of use in your personal life. I apologize for all the questions that we couldn't get into, but if you go to our webpage, many of them are answered. I want to thank the Union League for what it's doing to support all of our healthcare heroes, everyone who is providing any support they can to the League and its employees. Our members have been very generous to provide for those employees who have found themselves in a difficult circumstance. Bruce, we do that at Jefferson with our own. I know many places are doing it. And I'll just conclude by saying it's not for us to determine when we are called to duty. It's for us to determine how we will respond. God put us in this place at this time for a reason. We're so very fortunate to have you, Bruce Meyer, and thank you for joining us tonight.
Thank you all. Very much appreciated.
Bruce, Ed, thank you. You have our admiration, and on behalf of your fellow Union League members, I thank you for what you're doing for this fight, and thank you for sharing your knowledge and with all of our members, guests, and others. So thank you so much. Next week, we have another great program scheduled. And I know there were two questions thinking that we were in next week already, and that's COVID and the Constitution. And that's an important subject too. And I'm so glad that Bruce kind of mentioned that this all needs to work together. And we're going to talk about the United States Constitution. We have a great panel of experts that are going to join us. And on Tuesday, we actually have a virtual library hour on Thomas Jefferson, Lloyd DeWitt, his book, Thomas Jefferson Architect. So that's next Tuesday, the 12th, and then the 13th, COVID and the Constitution. On behalf of the Union League Legacy Foundation, I thank you for joining us tonight. Again, Ed and Bruce, thank you for your wisdom and sharing it. And we look forward to seeing you next week. Thank you. You guys were great. Oh, did Bruce jumped off, didn't he?